I wanted to point out a quick thing that I took from our session over in the Ross room. Paul had a chance to ask a question or two, and he also spoke up. I believe Paul's in the back there. And he has had ALS for 13 years, and we were talking about placebos and different, trials and things. And one thing he said was, throughout all of this, the number one thing that he feels has done the best for him is a positive attitude and finding things to be successful in every single day. There he is with a big thumbs up. Thank you, Paul. And I am no scientist, I am no doctor, but seeing my uncle go through this for 2 years, his positive attitude was so important to how his day was going to be that way. And I can't imagine. I know what the families are going through, what our patients are going through, but I just got to say, to see the smiles on all of your faces here together means a lot to all of us. So give yourselves a round of applause, because we got a great day today and a very, very special keynoter for you. Dr. Zachary Simmons is the director of the ALS Clinic and Research Center at Penn State Health Milton S. Hershey Medical Center. He helped create this nationally renowned ALS treatment center 30 years ago, right? You don't hear that too often. 30 years ago. I'm 31. It's almost older than me. That's crazy. He helped create it 30 years ago and has provided compassionate care and knowledge for thousands of people impacted by ALS. The Penn State ALS Center pioneered the use of telemedicine and remote monitoring in ALS. He was awarded the 2024 Forbes Norris Award by the International Alliance of ALS MND Associations for his clinical and research contributions to ALS. Dr. Simmons currently serves as editor-in-chief of Muscle and Nerve, and an ALS diagnosis is scary and stressful. We all know this as families and people who are diagnosed with ALS. But being able to approach somebody and help them, and having a team to approach and help them and give them that support, this is where it starts, is having that support system. Today, Dr. Simmons will share what he's learned from his exceptional career as he discusses an ALS Multidisciplinary Clinic as a successful model of care. Everybody, welcome to the stage our keynoter, Dr. Simmons.
Thank you so much for that very, very kind introduction. And I'd like to thank ALS United Mid-Atlantic for asking me to be today's keynote speaker. It's really a privilege to be here. And 30 years is quite a while, now that I think about it. I was noticing as I looked through the program this morning that almost everybody in their biography said how long they had been doing this, and I had neglected to do that, and it was a little bit intentional because it does seem like a very long time, but it's been a privilege for me to be doing that for all of these years, and the success of our clinic and of care in general of ALS United Mid-Atlantic, it's really based not on any one physician or even any group of physicians, but it's based on the incredible collaborative nature of what we do and the teams that we work with, for which I'm very grateful. So based on that, what I thought I would do today is really not so much highlight specific areas of research, because we have other people here who are doing that very, very well today. But I wanted to do was to take a walk through what we do for people with ALS every day, which is to see them in multidisciplinary clinic, and to go through the clinic model itself, looking at what we know works, looking at things that have changed over the years, looking at ways that we might improve care in the future, and really asking the question, how can we continue to provide and improve on providing the best possible care for people who have ALS, while the scientists continue to work on the research breakthroughs that are going to bring us new drugs and hopefully a cure. So with that in mind, what I'd like to do is then, let me just see here. Good. So how many of you have heard the following when you've been given a diagnosis or something along these lines? You have ALS, go home and get your affairs in order. Has anybody been given that sort of a line, and I see at least a few hands going up. And unfortunately, this is what I hear people tell me that they've been told, not obviously by every physician who gives them the diagnosis, but by a number of people. And I find it to be very, very frustrating and really unfair, because there is a great deal that can be done not only for people who have ALS, but by their caregivers, their family, and by their healthcare providers. And that's really what I wanted to spend today discussing. And of course, as you know, the team approach is the standard of care. One of my favorite teams, the MASH team. Best care anywhere. I think it's really a good way to summarize really what we try to do. I mean, for years we've joked that our goal is best care anywhere, and I think that this typifies what we try to do. So when we provide care for people with ALS, we do it as part of a multidisciplinary team, and as you can see, the person with ALS is at the center of this circle, and then surrounding them and providing care are physician, nurse, but many other important members of the ALS multidisciplinary team who are all of equal importance and who all contribute to the well-being of the individual. So the question is, multidisciplinary care prolongs survival, and we know that it improves quality of life compared to conventional care, and those things have been shown in a number of studies. And I think that it's important to emphasize this, because it's not only that multidisciplinary care is supportive, but it truly does provide improved survival for people with ALS. Why? It's because many of the recommendations that have come out over the years for how to best manage ALS are implemented more promptly and sometimes to a more expert degree in multidisciplinary clinics because of the expertise of people who manage that care. The fact that it improves quality of life is an added bonus to that as well, of course. But the model for ALS care has been the same for even longer than I've been doing it. It's really been the same for the last 40 years or so, even though the specifics of the care within that have evolved. So what I wanted to do today was take a look and see what aspects can be retained and what aspects might be improved to continue to provide people with best care anywhere. And what I wanted to do was start out with what happens even before a person diagnosed with ALS comes to ALS clinic. In other words, can we do better in terms of delays in diagnosis? And this is something which I've discussed with our patients, with their caregivers, and with a number of people in the ALS community a number of times. And what I'm often asked is, why is ALS so difficult to diagnose? Or a variant of that is ALS really so difficult to diagnose, and why did it take so long for me to receive that diagnosis? And I think it requires a bit of a step back to understand why that might be. Because there are a lot of reasons that people who ultimately are found to have ALS are not initially provided with that diagnosis. The most common of them is that there are many more common disorders that mimic ALS, particularly when ALS is in its early stages. For example, carpal tunnel syndrome and other nerve entrapment. So somebody walks into their doctor's office, they have a weak hand, the physician takes a look at it, and he or she says, might be carpal tunnel syndrome, you've got a weak hand. And 99 times out of 100, that really might be what it is, but sometimes it's simply not. People can have disease in their cervical or lumbar spines that can compress nerve roots and give them weak arms or legs. That's a much more common thing, but ALS can initially look like that. If a person has a stroke or a brain tumor, that can produce slurred speech, it can produce difficulty swallowing. People are often mistaken for that. And there are also neuromuscular disorders beyond ALS that can produce either speech difficulty or swallowing difficulty or muscle weakness. So the spectrum of things that primary care physicians have to think about at initial presentation is quite broad. And so when patients initially present to their primary care physician with symptoms that later evolve into ALS, the possibility of ALS is really not as high on their list of possibilities as some other much more common conditions. And I'm not providing this as an excuse, but I'm providing this as a perspective when people ask, why is this so difficult? And the other challenge is that the testing that we do may not provide sufficient clarity. As you all know, we can't simply do a blood test or a skin sample or a urine test and say, you have ALS. It's not that easy. And so as we do the tests to identify whether someone has ALS, many of the tests we do produce findings that muddy the waters a bit. So individuals who have ALS are often in their 50s, 60s, 70s, and they often have structural abnormalities of their spine, degenerative changes, disc disease, and so forth, or may have other incidental findings on their MRI that can be presumed to be the cause of their deficits. So if somebody is 65, 70 years old, they have a weak arm, they walk into their doctor's office, doctor says, well, sometimes that comes from the neck, let's do an MRI of your neck. They do an MRI of the neck. A lot of the time you find abnormalities because we all get those as we get older, and so sometimes the people are sent for surgery. And it's only when the surgery doesn't work and people continue to get weaker that the question then comes, well, there must be something else going on. What could this be? And it turns out that even EMG and nerve conduction studies, which we usually rely on as really not quite a gold standard, but certainly a very, very important test to help us diagnose ALS, it's not a specific test for ALS. So for other difficulties, other problems that show up on EMG can mimic what the person has. So for example, if you do an EMG on somebody, it's not uncommon that they'll have carpal tunnel syndrome. 5% of the population has it. So if the person has a weak hand and they're found to have carpal tunnel syndrome, an assumption is made that's what's causing their weak hand, they get surgery. Or another nerve entrapment could cause that as well. So it's important to keep in mind that even an EMG, which we think is giving us the diagnosis early on, may only show some other problem which isn't the main underlying cause, but is just an incidental finding. So how long does it take for patients to receive a diagnosis of ALS? Okay, so the article that was published not very long ago looked at 353 patients diagnosed at an ALS center in Sweden, and the time to diagnosis, which has not changed in 30 years, was about a year. And what I've put here is that the time at that center to diagnosis was 12.9 months. If in individuals who they took care of, in whom the symptoms started out in a leg, it took an average of 16 months to arrive at a diagnosis for those individuals. And the shortest one were people who began with respiratory symptoms, which is an uncommon form of ALS, shortness of breath, as the initial presentation. But even those people took 8 months to get a diagnosis. And when I look back at a number of previous studies, as far back as 30 years, it took about a year, 30 years ago, to get a diagnosis of ALS, and it takes about a year today to get a diagnosis of ALS for a patient. So the numbers have not changed substantially. And it's a long diagnostic journey because the people with limb onset are often sent to an orthopedic or spine specialist for possible spine disease for the reasons I discussed earlier. People with bulbar onset are often referred to ear, nose, throat, or general neurology. Maybe they have a stroke, maybe they have myasthenia gravis, maybe they have a vocal cord problem. And if they have respiratory onset, if it starts out as a breathing problem, of course, they're going to get evaluated for heart and lung disease as the initial thing. So it really does take a while for people to make their way to see us. And in this slide, which is from an article that we published not very long ago in the journal Neurology, the point in highlighting this was to show that at the beginning, in the upper left-hand portion of this, where I'm putting the arrow here, if the symptom onset is here, and it takes 12 months to get a diagnosis, which is over on the other side of the slide here, it takes this long because there are all these possible steps between that a person may go through. So for example, when they start to look for a diagnosis, when they start to look for a diagnosis, they usually go to their primary care physician, who has to think of so many other possibilities as to what could be causing this, which may result in referral to other specialists, a number of other tests, It may result in a referral eventually to a general neurologist, and that may result in other tests before one gets to an ALS specialist neurologist and before one gets to multidisciplinary clinic. So there's a lot of ways to go through this, and I'm sure for those of you who are in this room who've been through this, it can seem like a very arduous journey and can be very frustrating for most people. So some people have taken a bit of a cynical look at this, and they'll say, ALS is a fatal disease. Why, what's the hurry? What does it matter? And my answer to that would be, it matters a great deal. Earlier diagnosis facilitates initiation of multidisciplinary care, which, as I've said before, prolongs survival and improves quality of life. It allows us to start disease-modifying therapies, and I'll talk a bit about those. It allows us to start non-pharmacological means of prolonging survival, ventilation, nutritional support, and I'll talk a bit about those. It enables better management of symptoms, saliva, coughing, depression, a number of different symptoms that people get, muscle cramping, for example. And it allows earlier attention to the cognitive and behavioral impairments that may accompany ALS and to the advanced care planning, which is such a key part of care for people with this condition. The disease-modifying therapies, think riluzole, think Radicava or Edaravone, these are largely neuroprotective, meaning that they don't repair motor neurons that are damaged, but they do reduce the damage to undamaged motor nerves and slow the rate of progression of disease. And so it is important to try to start these therapies as early in the disease course as possible, when the number of surviving and healthy motor neurons is the largest. And one thing that comes out of all this is that riluzole, which has been around for decades now, is really a better drug than one would commonly think. And what do I mean by that? Well, the initial trials for riluzole showed that on average it prolongs life expectancy for 2 to 3 months. And all of the text on this slide isn't terribly important. What's important is the information here in the yellow bar at the top, which says that the registration trials, the trials for approval, demonstrated 2 to 3 months extended median survival for people with ALS compared to those given placebo. And those articles were published in 1994 and 1996. So we've been dealing with riluzole for a long time. So the question becomes, is that true? Is that what we should be telling our people, that if you take riluzole, it will probably prolong your survival by 2 to 3 months? It turns out that that's a great oversimplification for several reasons. First of all trials are based on averages, so that we don't know in any particular individual to whom we give riluzole what the benefits or not of that drug might be. If you have an average prolonged survival of 3 months, you're going to have some people in whom it prolongs survival a year and other people in whom it doesn't help at all. The second point, which I think is at least as important, is shown in this slide. So what this slide shows is that the median survival advantage for riluzole based on no riluzole is probably more than a year. It's probably not just 3 months. And here's why I say this. The first two sets of bars at the top of this slide show how long people with ALS live when they're treated with placebo, which is the yellow bar, versus how long they live versus when treated with riluzole, which is the blue bar. And so these first two studies, which were published in 94 and 96, showed a 3-month survival and a 2-month survival for people taking riluzole compared to placebo. However, people looked at that and said, how accurate is that? So over the next few years, people did other studies. Now, because the drug was already approved, people couldn't be randomized to drug or placebo. But what we could do is we could take clinics where people were taking riluzole and clinics where people were not taking riluzole, and doctors could look at their patients and say, okay, I'm going to take patients who are otherwise similar, we're going to match them, look at patients who are similar to one another, and we're going to say, how long do people taking riluzole survive versus those who didn't take riluzole? And when they did that in that way, matching people up for other characteristics that were the same, their age, their sex, their other medical problems, they found that the average survival for riluzole was probably at least 10 months and maybe as long as 19 months compared to people who were taking placebo. Now, that doesn't mean that in any one individual that will be the survival benefit, but it does mean that on average, riluzole probably works better than we think. The other reason that these studies showed that, I think there are two other reasons beyond simply the ones that I've gone over previously. I think one of them is because in the original riluzole trials, people had very advanced disease. That was how the study was done at that time. These were people in very, very late phases of ALS. Fewer surviving motor neurons, less of an advantage for riluzole. I think the second thing is that over the years, care has simply improved. And so that would explain the longer survival. It wouldn't completely explain the difference between people receiving riluzole and those not in these clinics, but it could explain the generally longer survival. So how can we ensure that people get a diagnosis more quickly, or can we ensure that? So I was fortunate enough to be asked to write a paper with Dr. Mitsumoto and Dr. Kasarskis a couple of years ago where we actually asked this question. And to highlight the key things, what we identified were there were some challenges. The first challenge is the education of general physicians and surgeons so that they think of ALS more quickly despite the fact that it's a rare disease, and that's not so easy because these physicians see lots and lots of patients who have lots and lots of other things. And the second is the role of neurologists in this. Are we seeing people fast enough, or are we taking all this too casually as well? Because certainly all of the blame here isn't on other physicians. And when I say role of neurologists, what I mean is developing a sense of urgency to save motor neurons in ALS and prioritizing patients with a potential diagnosis of ALS for an appointment for EMG testing for other studies. What could be more frustrating to somebody who may have ALS than for their doctor to say to them, I'm really concerned you might have ALS, so I'm getting you an appointment with an ALS neurologist. It's in 6 months. You know, what could possibly be more frustrating than that? And I'm sure I see a lot of heads nodding. Many of you have heard that story. And so it's not only on the docs that see you, and it's much of this is on us. And so I think it's very important that we as a community look at that and try to address that. Clearly we discuss this sort of all the time, and each medical center and each set of physicians has its own challenges to deal with. What we've set up at our center, and I know that we're not unique for that, is that when people are referred into our neuromuscular group, it's been me for the last few years, screens the referrals, and when I see somebody that's either referred as ALS or in whom, looking at the record, I'm concerned that they have ALS, we prioritize that, and we make every effort to see that they're seen within a month, and preferably within 2 weeks. Now, how do we educate our colleague physicians about this? I've put in red, I think, the 3 key words that really are things that should spark the thought, could this be ALS? Progressive, asymmetric, focal, painless weakness. That is usually a sign that this is not carpal tunnel, that this is not a nerve entrapment, that this is not a pinched nerve in the neck. If it's focal and painless and people don't have numbness and tingling, that really should make people think, could this be ALS, or at least think, could this be neurological as opposed to a pinched nerve? If we're able to convince our colleagues to think that way, we're okay with getting unnecessary referrals that turn out not to be ALS. So of the people that I see in our clinic for newly diagnosed possible ALS patients, they're sent in for a possible diagnosis. About 2/3 of our patients have ALS and the other third don't. They have some other thing. And that's okay. We'd rather see some people early and tell them they don't have ALS than see everybody with ALS late. Okay, so that's even before you get to ALS clinic. So then once you get to ALS clinic, are we doing everything in the best possible way there? And I would say that we may not be with regard to cognitive and behavioral dysfunction. I know that this afternoon there will be a talk that's focused specifically on that. So I'm not going to be giving lots of details here, but I did want to emphasize that there's an unfortunate tendency in much of what's written about ALS to say that people remain trapped in their bodies but remain intellectually alert and don't suffer any cognitive dysfunction. Now, fortunately, that's true for many people, but unfortunately, it's not true for everybody. And it's important that we, as physicians, make our patients aware that this can be a problem, because many patients later, when surveys are done, say, nobody ever told us, meaning the patient themselves and their caregivers, that this could happen. We were shocked, that he or she started having difficulty with their thinking, had personality changes. We didn't know. And so cognitive and behavioral dysfunction is not uncommon. If you look at it globally in ALS, more than half of people with ALS develop some degree of cognitive or behavioral dysfunction. Fortunately, that's usually quite mild. But in about 10% of people, it is severe enough that they do meet criteria for what we call FTD, or frontotemporal dementia. And for most patients, it's what we call a behavioral variant. So people undergo personality changes. They can become apathetic, or they can become precisely the opposite, disinhibited, doing inappropriate things in public settings, talking to people they don't really know, or being unusually friendly to a stranger, or that sort of thing. They can also show poor insight, not really understanding that they have a deficit. They can have a lack of empathy, not realizing that they're treating other people in a way that really shows a lack of concern, and they can become impulsive. So if you put a big plate of food in front of them, they just eat everything, as opposed to using judgment, for example. And they may make inappropriate decisions regarding finances or safety. I remember a patient of mine, actually his wife, his caregiver, saying to me, she said, well, we knew there was something wrong because he used to make fun of my watching QVC, and then he started buying stuff on QVC, and he didn't even need any of this stuff. And she said, was this it? And of course it was. It's that lack of judgment, the impulsivity. And when cognitive, as opposed to behavioral, it can be manifested as a decline in language skills. And many of you have probably seen this, that people with ALS, even though they can't speak, they may be typing or writing, but then sometimes their language skills will decline so that when they type, some of the words don't make sense, they're grammatically incorrect, they write things, but they may choose the wrong words. That can be a part of this as well. And it worsens over time. What this shows here is if you look at different stages of ALS, defined by something called the King's scale, you can see that the bars become progressively higher, and the higher the bar, the larger the percentage of patients that are demonstrating these aspects of cognitive and behavioral dysfunction, apathy, loss of sympathy, eating behaviors, and so forth. The more advanced the ALS, the greater the chance that people will exhibit these traits. And we should be concerned about frontotemporal dementia because people survive for a shorter period of time when they have ALS and FTD than when they just have ALS. They're less likely to comply with recommendations for care. They require simpler tools to communicate. When they try to eat, they may not modify the diet as recommended, and so they may choke more. They may eat things that they shouldn't eat. They may aspirate. From a safety point of view, they may not use their walker, they may not use their wheelchair because, again, their judgment is off, so they may fall. And of course, it impacts their capacity for decision-making regarding end-of-life care. Should they have do they want to have a tracheostomy? Do they want mechanical ventilation? Do they want a feeding tube? What about their advanced directives? Ultimately, people who develop FTD cannot make these decisions properly, and this is something that we all need to be aware of. So I think, what can be done? I don't know that we always do this as well as we should in multidisciplinary clinic. And it really requires recognition and discussion with family and caregivers, leading to a better understanding of why their loved one is acting this way. It's really important for us as physicians to inquire about these sorts of things, even though these can be very difficult conversations. Somebody has just been diagnosed with ALS a few months ago, and they're having a great deal of difficulty speaking, walking, using their hands, breathing, you name it. And then on top of that, we're asking, is their behavior changed? Well, of course, they're going to have some natural changes in their behavior. They may be depressed. They may be have a number of normal emotional reactions to having a devastating condition like this, but are we seeing the warning signs of FTD? And if we are, how can we help the family to cope with those? How can we implement safety measures to prevent choking or aspiration, to monitor for falls, to assure they have proper supervision? And how can we support their caregivers? There's been study after study that shows that the burden on caregivers, as assessed by those caregivers, for people who have ALS and FTD is much higher than the burden for people who have ALS alone or who have FTD alone. So if you asked, how can we improve multidisciplinary care after we get people into ALS clinic, this is certainly one way we can do better. I think another thing we have to look at is, are we doing things right with regard to non-invasive ventilation? This person is wearing what we call a BiPAP mask or a non-invasive ventilatory device. And when do we start non-invasive ventilation? Because I'm not sure, and a lot of ALS physicians are saying this is not unique to me, that we're starting this at the right time, that we're starting it early enough. So traditionally what we do is when a forced vital capacity falls below 50% of predicted, or a maximum inspiratory pressure is less than 60 centimeters of water, that's when we start an NIV device. And starting non-invasive ventilation is important. People who need this are not doing well often, because in one large study at the University of Pennsylvania, within 1 year of starting non-invasive ventilation, 37% of patients, more than a third, had died. So when we start non-invasive ventilation, this isn't an early stage of disease. But are we starting it early enough? And so non-invasive ventilation has a lot of benefits. It absolutely prolongs survival, and it absolutely improves what we call health-related quality of life. For example, it improves symptoms of underbreathing, fatigue, waking up with morning headaches, waking up multiple times during the night, having to sit up during the night in order to breathe properly, and then going back to sleep. And it literally slows the decline in the rate of progression of ALS. So starting it is important, but when? So we use 50%, but is that really the right number? 50% are predicted for forced vital capacity. I'll just say as an aside that the reason we use this 50% is because that's when Medicare says that they will pay for non-invasive ventilation. The Medicare rule is we will pay for NIV when FVC is less than 50% of predicted. They also say that they will pay for it when their maximum inspiratory pressure is less than 60, and that's a more sensitive marker. We don't always use it as much. But even the 50% may not be a good marker. For example, there was a study done many years ago that looked at people when their forced vital capacity was 65%, and it started a non-invasive ventilation then, versus a group who they started it at below that level. And they found that starting it early at 65% was more beneficial. And this was years ago. Well, maybe it's not 65%, maybe it's 75%. So there was another study done also several years ago that looked at patients who had their non-invasive ventilation started at 75% of predicted versus those who had it started at less than 50% of predicted. And they found that people who had it started at less than 75% did in general better. And there were two studies, one as recently as 2023 and one a number of years ago, that pointed to that. Start it at 75% rather than 50, people may do better. So maybe it shouldn't be 50, maybe it should be 65, maybe it should be 75, maybe it should be 80. So a study that was published just a few years ago looked at a large group of people with non-invasive ventilation where they started at 80% versus those who they started at less than 80%. So a very early group, forced vital capacity 80% or greater, versus what they called a later group, FVC less than 80. So this was just greater than 80 versus less than 80. And they actually found that starting at very early, greater than 80, people did better. So it may be that 80% is where we should be starting it. So I'm not sure that, that our current guidelines of starting it at 50% are really serving our patients in the best possible way. Are there ways of getting around that There are, in terms of using maximum inspiratory pressure, which gets it a little earlier, and there are other ways as well, and I'll mention those just in a little while. So that's non-invasive ventilation. I think another question is, are we doing the best possible job with weight maintenance and gastrostomy? And the answer is sort of, but I'm not sure we always do. So one thing we do know about feeding tubes is that earlier is better if people are losing weight. And so what I mean by that is that if a person has greater weight loss from time of diagnosis to the time that a gastrostomy tube is placed, a feeding tube is placed, they will have a shorter time of survival after the feeding tube is placed. That is, if people say, well, doc, you're saying I need it now, but if I just wait 2 or 3 months, is that going to harm me? The answer, unfortunately, is yes. The answer is, if we see some indicators that you need this now and you wait, it will result in shorter life expectancy. The decision, obviously, is always up to the person with ALS, but we can with assurance say that. Preventing or minimizing weight loss from the time of motor neuron disease diagnosis and encouraging use of non-invasive ventilation when clinically indicated are both modifiable factors that may prolong survival of motor neuron disease patients with a gastrostomy. So it is important that we look and try to get the jump on this, so to speak, that we be proactive in terms of minimizing weight loss. There was an editorial that was written just earlier this year, which I think really put it very, very nicely, and it was written to accompany an article about gastrostomy placement in ALS in muscle and nerve. And so what Dr. Petit said in this was that dietary and nutritional management strategies should be standardized early in the disease course, emphasizing a high-calorie or protein diet and advocating timely gastrostomy discussions upon recognizing substantial premorbid body weight loss. Well, what does substantial weight loss mean? For most dietitians and for most people who specialize in nutrition, 10%. If a person has lost more than 10% of their weight compared to what their usual adult weight was prior to ALS, that's the time to start being concerned that they're experiencing meaningful weight loss. You know, this is not somebody who 2 years ago went on a diet and lost 20 pounds and has been stable since then. This is somebody whose weight had been at a certain level and then says to you, my symptoms started in August, and you're seeing them in February, and they say, I've lost 30 pounds since my symptoms started. That really should raise a concern. Ultimately, it must still be recognized that gastrostomy is a major clinical and personal decision, so of course, and it's one that the individual with ALS makes, not that the physician makes. But the data to date confirm that the initial discussion of gastrostomy should begin promptly following the ALS diagnosis and continue throughout regular intervals, maximally optimizing all clinically achievable benefits. This doesn't mean that anybody who's lost 10% of their body weight needs a feeding tube. But what it does mean is that early on, as physicians, we need to do a better diagnosis of emphasizing to people, you really need to try to maintain your body weight. And this may mean working very closely with a dietitian in ALS clinic to increase their calories, to get foods that they can swallow more easily while maintaining their calories. And then if weight loss persists, explaining to the person what a feeding tube may add, and then answering questions people may have so they can make an intelligent decision and an informed decision regarding the need for gastrostomy. So that's one other aspect. So another aspect of ALS clinic, which I think we can do a better job on, is pain management. So one thing that one often reads about ALS is, and I even said it earlier, painless progressive asymmetric weakness. Well, yes and no. Classic ALS, yes, but if you look at everybody with ALS during the course of their illness, is it always a painless weakness? The answer is unequivocally no, it's not. And it turns out that pain is common in people with ALS. So there was a survey that we were a part of that was published a number of years ago that looked at 424 participants across the U.S. with ALS. And it turns out that 75% of people with ALS reported substantial pain at some point during the course of ALS. When I say substantial, I mean pain beyond the everyday kinds of pain that people say, my back hurt for a day, or I had some headaches. This was people who had some pain that was sufficient enough to complete the survey to say they had pain beyond their usual pain. And 82% of them said that this pain was due to their ALS. And 34% said that it was present even at the onset. So as I said, although classic ALS is painless, progressive, asymmetric, 34% of people would say, well, mine wasn't painless at onset, and we need to keep that in mind. And the pain isn't limited to cramps and spasms. I really like these two graphs because the one on the left shows the body region affected by pain, and the one on the right shows how patients describe their pain. And look at how diffuse the pain is. Legs, neck, arms, shoulders, back, hands, it's really widespread. And look how differently people describe it. It's not just cramps and spasms, which by themselves can be, of course, painful and meaningful, but aching, tingling, nagging, sharp, tender, exhausting, miserable, shooting. People had a variety of different descriptions. We really need to pay attention to this and hear what people are saying. The use of pain medicines is very high among people with ALS, and treatments by people with ALS are often perceived as being inadequate. In this survey, 80% of people reported taking some form of pain medication. 22% of them said they were taking opioids, but a quarter of people felt that they needed a stronger form of pain medication than they were being given. And doctors have, been sort of buffeted back and forth on this whole thing, right? There were a time 20 years ago when everybody was saying, well, just give people OxyContin, right? It's non-habit forming and it really helps pain. Well, that turned out not to be true. And so doctors have gone the opposite way, which is, I'm not prescribing opioids, right? And so, our patients are caught in the middle. And particularly cancer patients and people with ALS who really do suffer pain and have terrible conditions that really have to be managed from a life expectancy point of view and from a quality of life point of view are the ones who suffer as a result of this. Because 14% of this sample said they needed to take more pain medication than was being prescribed by their doctors. So I really think we need to listen and have a conversation and use pain medication sensibly in terms of what people need when they need it. My worry, my concern about my patient with ALS becoming, quote, addicted to pain medication when they are profoundly weak and perhaps even having difficulty breathing should not be the highest thing on my list for somebody who is suffering. Pharmacologic and non-pharmacologic treatments can be used and have been used, everything from antispasticity medications to agents for nerve pain like gabapentin, to non-narcotic pain medicines, ibuprofen and that sort of thing, to other things, and including, and should not be neglected, therapies, physical therapy, complementary alternative medications, medical marijuana, biofeedback, cognitive and behavioral feedback. There are a lot of ways to treat pain, and our patients don't all want a pill. And we need to be open to that, and we need to be able to say to them, what are you comfortable with? And some of them, they say, I don't want another med. Well, we do have a lot of other options. Let's work on those. Unfortunately, many physicians feel undertrained in terms of what we should prescribe. So almost 2/3 of physicians in the survey reported that there's a need for better pain management practices, and more than 1/3 felt that they needed better training. So part of this is, again, on us. A lot of neurologists, who are often the doctors who you end up seeing to treat your ALS, don't always feel really comfortable that they have true expertise in pain management. This may be one part of the equation where, for example, palliative care may be of great help because they do have expertise in pain management and often can help the ALS physicians in managing this. So I think we need to educate and train ALS specialist physicians and other members of our multidisciplinary team so to optimize pain control using both pain medicines and non-pharmacologic measures, and there are many ways to do this. So as I thought about other ways that we could potentially do a better job with ALS care, I thought, well, how much does telehealth help or can Can it help us? And are we using it adequately? Now, 40 years after multidisciplinary clinics began, when we had no idea that telehealth was even a possibility. So to understand this, one should look at the pluses and the minuses of multidisciplinary care. So the positives are obvious. One-stop shopping. You get integrated care in one place. The healthcare providers have expertise, and they're researching clinical trials. The negatives are that it's a long day. Takes a while to get to clinic, you're in clinic for a long time, and for someone who has to get ready for the visit, travel an hour or two to get to clinic, spend 4 hours in clinic, go home, and then get settled for the day, it's a long, long day, both for the person and their caregiver. And to reinforce this, it turns out that nearly half of people with ALS in the U.S. live at least 50 miles from an ALS center, and a quarter live more than 100 miles from an ALS center. So many people really struggle with this. And if you look at how much time do family caregivers spend caring for an average person with ALS, it's 11 hours a day on average, some more, some less. So there are a lot of burdens that we have to look at when we think about what can we do to relieve those burdens. Ideally, can telemedicine help? Can it provide multidisciplinary care, and can it reduce travel time and burden? It could in 3 ways. You could use it as a substitute for the regularly scheduled multidisciplinary visits. You can use it to decrease the time in multidisciplinary clinic by having some one-on-one visits with specific providers before clinic, or you can use it on an as-needed basis for urgent care. And all of those might reduce burden. Now, what we did at our place is we asked people, what do you like about multidisciplinary care? What don't you like about multidisciplinary care when it's given through telehealth? And what we found is what they liked, not surprisingly, didn't have to travel, liked being in my home, saved time, I was less fatigued, and it was more comfortable. What didn't they like? It turns out the things they don't like are, to some extent, addressable. It seemed more impersonal. That's really a personal preference, and one has to weigh that against the potential advantages. Problems with audio and video can usually be overcome. The lack of privacy, in other words, if they didn't want their spouse to hear something, they couldn't ask them to leave the room because they were there. Some of them actually didn't like not getting out of their home. They liked leaving their home to go to the visits. But the dislikes were, in general, either manageable or could be to some extent overcome. And so what we've done now is we have about 15% of our ALS clinic visits are made by telehealth. And I'm not saying that's an ideal number. I'm not saying it's better than other clinics. I'm just saying this is what we've ended up as balancing, is about 50% of our visits are telehealth visits now, always and only at the request of one of our patients, if they say this is what I want. And when we looked at our telehealth visits, most of them replaced the entire multidisciplinary clinic visits when we looked at this data initially, meaning that we found that the average remote visit by telehealth was almost 2 hours, and it varied from, as you can see on this pie chart here, from anywhere from up to 1 hour, which is blue, up to 2 hours, which is orange, up to 3 hours, which is gray, and even up to 4 hours, which is this yellow slice. So when we initially started doing it, we found that we could do multidisciplinary clinics this way. The person was at home, and the multidisciplinary team walked into the computer room, one at a time or two at a time, and did their multidisciplinary clinic visit that way. Were there limitations? Sure, and I'm happy to discuss those at some point. But it was a doable thing. About 15% of the visits when we started doing this were individual visits. In other words, they didn't meet with the whole team, they just met with one person. And these visits were shorter. As you can see, they varied anywhere from, they varied anywhere from, they averaged only 27 minutes, and they varied anywhere from the 20-minute block here to the 40-minute block here to the 41-plus minute block here. So shorter, but you can do one-on-one visits too. And we found out that distance made a big difference. If you look at how far away people live, we found that our telemedicine patients on average lived much farther away. In other words, 78% of our patients here on the right who came to in-person visits lived within 50 miles, but that was true only for 56% of our telemedicine visits. Most of our telemedicine visit patients lived farther. They also tended to come from more rural areas, so I sort of like this map here. So here's our center, this in south central PA here, and if you draw 50-mile radius circles going out from that, you can see that the farther out you get, the more visits are these types of markers here, which are the telemedicine markers, because it's harder for people to get in, and these are rural areas. So more visits by telemedicine there. As you get closer, more visits that are in person. But notice that even for people who live close, some visits are telemedicine, because depending on one's personal situation, it may be very hard to go 5 miles. And then, not surprisingly, what we found is people who did telemedicine were more likely to have a lower functional rating scale score. In other words, they were weaker, and they were more likely to have a lower forced vital capacity. So those are ways that telemedicine can be used. Is it a substitute for in-person care? Absolutely not. There are limitations, particularly on things like physical therapy visits, where one can show things but not actually do them with the person. Are there ways to do, are they beneficial? Because our patients continue to request them, our take on that would be yes, they are. There are other ways to reduce the burden as well. You could do in-home monitoring. So you can do pulmonary function testing in a person's home by giving them a portable spirometer. And we did a study a few years ago where what we did is we looked at a comparison of the accuracy of doing a pulmonary function test in clinic versus the accuracy of sending somebody home and having them do their pulmonary function testing at home with proper training. What we found is that the results are almost exactly the same. If you train the person properly, they can produce an accurate pulmonary function test. This is demonstrated on these two graphs by the fact that the dotted line on both graphs would be the line that you would expect for perfect agreement between the remote test and the in-clinic test. The solid line is the relationship that we actually got. And you can see the solid line and the dotted line are very, very close to one another on these two graphs. And that applied for both forced vital capacity and maximum inspiratory pressure. So you can get accurate results with people at home doing pulmonary function tests if they're trained properly to do this. Why might that be beneficial? Well, think about ALS. We bring people into clinic every 3 months. Why? Well, because we've always brought people into clinic every 3 months. We try to balance the burden versus the necessity, and this is the way it's been done for years. Nobody chose 3 months because it was scientifically proven to be the right interval. They chose 3 months because they chose 3 months, and that's what we do. But and it's worked. But ALS is heterogeneous, right? It has slow progressors, moderate progressors, and fast progressors. Is doing a pulmonary function test every 3 months, does that make sense? And the answer is maybe it doesn't. So we did a study where we looked at weekly home pulmonary function testing in people with ALS, and we asked, if we did a pulmonary function test in your home every week, could we start non-invasive ventilation sooner, even if we didn't change the bar, even if we said you have to hit 50% of predicted in order to start NIV? Would you start it earlier if we simply tested you every week? And the answer, not surprisingly, was, well, yeah, because sometimes by the time the person comes into clinic, they've gone far below that 50% mark. They're at 40 or they're at 35, even though at the last clinic they were at 55. But if you test them more regularly, you can pick it up earlier. And we found that on average, people started their NIV almost 2 months earlier by doing the home pulmonary function test than if we only did them once every 3 months in clinic. So thinking about doing home PFTs really can give people better care. Another way of possibly doing this is a study that we're involved in, and we're doing collaboration with UPenn and some other centers, and it looked at transcutaneous carbon dioxide, which might be an alternative to measuring spirometry and maximum inspiratory pressure. So, it's hard to do spirometry when people have bulbar ALS. It's hard to form a seal around the mouthpiece. It's hard to use a mask because often people can't coordinate their breathing measurements well enough to do the test properly. So it really is not a reliable test in people with bulbar ALS. And so the guidelines of 50% or minus 60 fall by the wayside when people have really severe bulbar ALS. But what if you could measure their carbon dioxide levels? Well, typically you would get a blood gas measurement, which means you have to put a needle into an artery and measure their oxygen or carbon dioxide levels, and that's not a test that we can just simply do at home. It's typically done in a hospital or a pulmonary function lab. But we can use a skin sensor to measure carbon dioxide levels on people. And this is fairly new technology, but in one study that we were involved in, we found that high carbon dioxide levels, which are a sign of underbreathing, occurred in half of our patients and preceded the low forced vital capacity in all of those patients. In other words, when we found a high carbon dioxide level at night in these patients wearing their monitor at home, that meant that they were underbreathing, but we would never have picked that up in clinic because all of them had forced vital capacities of at least 50%. So there are better ways of monitoring people for underbreathing. We're just not currently taking advantage of them as well as we can. What if we said, well, we're not going to look at FVC, we're going to look at maximum inspiratory pressure? Well, even then, there were 3 of these 7 people that wouldn't have been put on non-invasive ventilation because their maximum inspiratory pressure didn't reach the threshold, but it did reach the threshold with carbon dioxide monitoring. So home cutaneous CO2 monitoring can identify respiratory dysfunction prior to standard of care testing. The challenge is going to be in implementation. Not all respiratory therapy companies do this. It's not always approved by insurance. It's expensive. The monitors are somewhat fussy. We're trying to figure out best how to get these monitors to work and how people can apply them themselves. But I do think that this technology will be worked out in hopefully the next year or two, and this can become a practical sort of in-home test. I'm going to finish up with just a couple of other thoughts about multidisciplinary clinic. The one is that there are other types of monitoring that one could do at home that could potentially be helpful. Could we have sensors on people where we monitor their gait at home by putting sensors on their ankle or sensors on their wrist? So you could look at gait by putting sensors on their ankle and potentially identify people who are at risk for falling because of changes in how fast they walked and in changes in how big their gait stride was, how long their steps were. And we do have some data that show that you can get accurate monitoring of this at home and that people's gait does change. Well, what if you could do this? And what if you could say, oh my gosh, this person is wearing their monitor once a week, and this last week they're showing some changes that we know are associated with a 50% chance of falling. So instead of saying, well, we'll see them in clinic in 6 weeks, you could say, we really better do something now. Let's have the patient come in now for an evaluation by our therapist, or let's send a therapist out to their home, or let's have the nurse do a visit, or something that would assess this more accurately if we think they're at risk of falling. What about speech? So there are actually devices that can record standard passages and can do an analysis of speech rate, speech clarity, speech comprehension, and you can determine whether people's speech is deteriorating enough that we really need to be working on an augmentative communication device before they come into clinic and say, gosh, now, and their partner says, gosh, they can hardly talk at all, I can barely understand them. So there are ways to do that as well. Both gait monitoring and speech are being used frequently now in research studies, and the hope is that they will come into clinical use in the not too distant future. So the last point here is, so what about integrating research into multidisciplinary clinic, and are we doing the best possible job of that? And my answer would be that we should be. I think we often are, but I'm not sure we always are. So when we've done surveys of our patients, we've done them several times now over the last 20 to 30 years, we've found that they consistently show that people that we care for consider information about research to be a high priority. And yet the multidisciplinary clinic may or may not include that. In other words, depending on the clinic, It may be strictly a clinical visit, and the opportunity for research may not be there. And remember that research is not just clinical trials. Research is a lot of stuff. It's not only drug trials, but it's biomarker trials, it's environmental exposure trials, genetics, technology, symptom treatment, quality of care. I think it's important that we all, as physicians, think about incorporating research into our clinic and consider the research team to be an integral part of our multidisciplinary team. We treat them at our center, and I know many other centers do, as equivalent to our PT, OT, speech, and so forth teams in the sense that they get a block of time and they go in to see the patient during that clinic. And they explain our ongoing research studies, they give out flyers, they distribute handouts, and they arrange follow-up calls to people who express an interest. The research visits, we can't do a whole research visit typically, there's not enough time, but if all they need is a blood sample, we can do that during clinic. If we need to get informed consent and do a more involved study, we schedule a separate visit, but at least informing them of their options during clinic visit, I think, is very important, both from the point of view of the ALS community overall and to the individuals that we care for. So we've set up a separate ALS research website, independent of our clinic website, and I know that many other centers have as well. So I would say in conclusion that, multidisciplinary ALS care is essential, but the gaps in recognition and management persist. We need to work on more timely access to multidisciplinary care, as I discussed. We need to pay more attention to cognitive and behavioral dysfunction to prepare people proactively for that possibility. We need to pay more attention to respiratory insufficiency and really as a group of physicians decide whether we need to implement respiratory care earlier. And there are several initiatives going on to address that question more definitively. We need to, right now, be more concerned about preventing weight loss and providing nutritional support. We definitely need to ask people, are you in pain and how can we help that? And we need to integrate research into clinic. So I know that, compared to several of the talks being given here, which are talking about cutting edge basic science research, this is not what I'm discussing today. But my point today is to really say that this model that we've had for so many years, I think, is an excellent model. It does prolong survival, it does improve quality of life, and generally, most individuals that we care for do support this model of care. But that doesn't mean we should just sit back and say, great, this works, we're done. It means that we should continue to reassess this. And I would say while technology is not a substitute for in-person care, telehealth and in-home monitoring have the potential to improve access, reduce the burden, and improve safety. So my parting line would be, better drugs are being developed, but we must not neglect the resources we already have to improve the lives of those living with ALS. But I think Hippocrates said it better when he said more than 2,000 years ago, cure sometimes, treat often, comfort always. And I think as physicians, that's really, and as other healthcare providers, that's really our job, and that's what I would hope that we would do for people who are under our care. So this picture here, which I always love showing, is a picture of some of our patients and their caregivers at a plot of land that's behind the medical center where people can have a garden. And this is a bunch of our patients and their caregivers at their garden plot. And this slide here is just a thank you to all the people that make possible the care that we give, our research team, including our coordinators and our clinical team. So I appreciate your attention and thank you all very much. And I don't know if we have time for questions or I ran out of time. Or yeah, I'll defer.
Does anyone have questions? You have a few minutes.
In the back? Yeah.
Doctor, are you familiar with this supplement or medicine that's been approved for ALS early stage in Japan? It's basically like 50,000 milligrams of B12 injected. Are you familiar with this?
Yeah, I'll repeat the question just so everybody can hear. The question was about what they call ultra-high dose B12 injections, which have been approved in Japan for treating ALS. Yeah, so there's So when we say ultra-high dose B12, if you normally take a dose of B12 that you pick up in the drugstore, it's about 1,000. It's about 1,000 units, maybe 2,000 micrograms, and people normally as a supplement would take, 1,000 or 2,000 micrograms. Could take it daily, and if we give an injection, it's usually 5,000. The dose that they're giving in Japan is 50,000, and so I'm familiar with it. The data does look promising. I know that it's not therapy that's necessarily covered by insurers. In fact, it's typically not because it's not approved at that dose in the U.S. My understanding from reading the data is that the safety of the treatment does in general look good, but we don't have enough experience here in this country for me to say unequivocally that it's an absolutely safe treatment, but none of the treatments raised big concerns about safety signals. And the question was, does that slow ALS progression and prolong survival? And it appears that it would, but the studies are fairly small to date. Yes.
Question about the CPAP machine, sleep apnea. If the machines aren't working, I've heard of other options. Heard of like an implant, and then I've also recently heard that the FDA approved of Ozempic in microdoses helps with sleep apnea. Now, and there's another option like Ozempic, but it doesn't take your muscle mass away. And the FDA just approved supposedly. I want to know if you know anything about that.
Yeah, so the question was whether about alternatives to NIV, and in particular whether the use of Ozempic, which was approved for not for ALS but for people who use non-invasive ventilation for other means, could be beneficial. And I've heard about it, but I just don't know at this point what its applicability might be for ALS. I don't know of other physicians who are trying it. Perhaps you've heard of some who have. Yeah.
Networking through all this stuff.
Yeah. I've not heard of any of my colleagues right now who are trying other means such as that. But you're right. Not everybody can tolerate NIV. Right. Even with regardless of whether it's a mask or nasal pillows, some people still have difficulty with tolerance. Particularly people with bulbar, but not only people with bulbar dysfunction, people with claustrophobia, people with, who can't get a mask to fit properly. And that is a significant problem with NIV in the sense that it doesn't work if you can't wear it, right? I mean, to state the obvious, but I'm not familiar with people who are taking sort of a pharmaceutical approach to it yet. I'm just not.